Hey everybody, okay, we're going to pick back up where we left off with dietary guidelines. Those dietary guidelines are something the U.S. government, along with American Heart Association, American Diabetic Association, with a large group of conglomerates, have established guidelines to help people gain or to maintain proper nutrition, to help reduce disease processes or improve disease processes like cancer, diabetes, um, heart disease, obesity, to kind of combat or to prolong the increase the increase of that disease process over time by modifying diets. So dietary guidelines are put together by the USDA and the Department of Health. There are recommendations on eating a balanced diet. It's revised ever so often. The last revision was in 2005. There will be a new revision coming in the near future. One of the things that was modified was the food pyramid. So what you're looking at here is the way that we feel like food should literally be maintained, or what we should eat. We should eat more whole grains than we should other products. So we want a good supply of vegetables. We want a small amount of oils, fats, lipids, as you can see there, very small amount. Meats and beans, we want it to be our second lowest. Grains, we want grains to be our largest. That bulk of our diet should be grains. And then fruits and vegetables, and then as you can see there, dairy is very, very small as well, almost non-existent in that pyramid. So that's the order in which the USDA and the Department of Health and Human Services feel we should maintain our diet. Now, there are things we have to modify for people with different disease processes as well. So things we have to think about when we look at nutritional levels and what people need are their age, their health status. Are they a diabetic? Do they have heart disease? Do they have risk of heart disease? Do they have kidney disease? Do they have cancer? There are many things we have to take into consideration. Also, height and weight. If someone is on the low end of the BMI, if they're very thin, they may need a higher calorie intake as opposed to someone who is obese. Body frame. BMI does not take, body mass index does not take into consideration someone's body frame. But we all know, just by looking around the room, there are people who have a slighter or a thinner or a smaller frame, and those that have a larger frame. Bones are more dense. They're just a larger framed person. Body circumference. So what that means is the kind of like the equator of the body. How big around is the belly? If someone has a large belly and they have very thin legs, they're more at risk for diabetes and heart disease. So we have to take into consideration and look at their diet. Percent of body fat. Someone may be thin but not have a lot of muscle mass. Therefore, we would need to modify their diet to make sure they're getting enough adequate protein and maybe cut back on carbs and fats. Also, their current nutritional status. When we look at someone, we have to look at what they eat now and how does that need to change. And also, do they exercise every day? Do they exercise 3 times a week? Do they not exercise at all? Are they couch potatoes? We have to take that into consideration. And what kind of energy do they need? Someone who is ill may have different energy needs. Someone who has different disease processes, such as a thyroid issue or other things, they may have an altered nutritional need for energy. Also, when we look at nutrition, we have to look at their educational level, because we're going to be teaching them, so we have to be able to be sure that we teach the patient based on what they can understand. What's their lifestyle? If I were to tell someone who has a very low income that they need to eat very expensive fish all the time, that's not going to happen. Also, with beliefs, there are cultures that don't believe in eating certain types of foods, so we have to take that into consideration when we look at their nutritional status and their culture. We're in the South. In the South, we fry everything, so we have to take that into consideration and maybe find ways to modify that. Use something that's an alternative to bleached white flour and lard. Maybe incorporate a nut oil and some kind of substitute like almond flour or something. But there's things that we would do to modify that. Also, measuring fat related to their percentage of weight. And that's a skin fold test. It's measured by the thickness in the folds of the skin within with a specific machine that measures that, and it will tell you the total amount of body fat of a person. And then we have to take that into consideration to what is the normal body fat if they're a male or female, if they are 5 or if they're 75. We have to look at that and see, as we age, muscle tends to deteriorate and it's replaced by fat in the body. So we have to look at that. We have to look at someone's age, their nutritional status. There's so many things to look at when we consider diet. Things that we modify diet for. Pregnancy. You need about 500 calories more a day, 500 to 600 calories more a day for someone who's pregnant only. If someone has an injury or a wound, we need to make sure they're getting plenty of protein, zinc, and vitamin D, as well as vitamin C. Almost every American needs vitamin D because we don't get out in the sun enough. Disease processes like dementia or diabetes, cancer, heart disease, kidney disease. We have to look at their congestive heart failure, COPD. We have to look at all of those kind of things related to the diet. Are they a vegetarian? And are they a vegetarian who eats eggs and milk? A ovo vegetarian? Are they vegan? Do they eat fish? You have to think about what kind of vegetarian that they are. Also, where they are in life. Children need a different kind of diet than someone who's 85. And someone who has a history of or currently abuses certain kinds of illicit drugs or prescription drugs. We have to look at all of those things related to diet. So modifications are restrictions of certain foods. So when we talk about restrictions of certain foods, we need to think about, and I'm sorry, I'm going to switch back here for a second. We think about restrictions of certain foods, like a diabetic has to monitor their carbohydrate intake. Someone with congestive heart failure has to pay close attention to their fluid and their salt intake. I mean, there's emphasis on particular foods that they need to. Sorry, guys, I'm trying to get this to move forward like I want it to, and it's not wanting to. So we have to pay really close attention to specific foods that they have to restrict. We have to look at calorie intake. We have to pay close attention to all of the things that are necessary for modifying their diet. We have to think about their income. We have to think about all of those kinds of things that are important. Do we need to have them increase protein specifically for wounds? Do we need to have them modify the type of fats that they intake? Do they need to increase fish in their diet? Do we need to have them restrict their calories or maintain a certain calorie level? Maybe they need to be on 1,500 instead of 2,000, 1,800 instead of 2,000. Maybe they need to, like I said, sodium. They need to restrict protein if they have kidney disease. There's so many things that happen when there is a change in the diet that we have to take into consideration as we educate our patients. What about if someone has had a stroke? If they've had a stroke, we may need them to have a different texture. It may need to be mechanical soft. It may need to be a thickened liquid diet because they've had a stroke. Also, we may need them to eat more frequently. We may need them to eat 5 or 6 small meals. A diabetic needs 3 meals and 2 snacks a day, and one of those snacks needs to be before bed. Those kind of things that we have to know to educate our patients. We modify diets for patients with specific needs. People with food allergies. So we always ask on intake, are you allergic to anything? They never think about food. So we have to ask them, are you allergic to wheat, milk, eggs, chocolate, Are you allergic to nuts? If so, which nuts? Are there specific nuts? Are you allergic to potatoes? So we want to make sure that we have that documented, because say someone has to have surgery, if they're allergic to eggs make the anesthesiologist have to use a different form of anesthesia. We didn't document that prior to, our patient could be in some serious trouble. So if they're allergic to them, we need them to eliminate those foods. Things like anemia, we need them, if they have anemia, we need them to increase their iron, and we need to maybe give them an iron supplement. If they have cancer, they need more calories because of the way that the cancer affects the body, as well as, I'm so sorry guys, this thing is not wanting to be my friend today. If they have cancer, we want to be sure that they're increasing their calorie intake, because chemo, radiation, all those things, they really impact the body. The body also is trying to heal. Its immune system is trying to work. So we have to be sure that we educate them properly on what they need to intake. People with, and I apologize, our internet is crazy today. They have to have plenty of protein. You cannot replicate new cells without appropriate protein. You guys know that from DNA, RNA, way back in biology. And we're breaking down cells really rapidly in their body with that chemo and radiation. Diabetes, we need to teach them the carbohydrate exchange program. There's a specific food pyramid for diabetes. We need to teach them how to monitor their carbohydrate intake along with their medications. And then in elderly, we have to look at what their metabolism is, what medications they take, what they're able to chew. Do they still have all of their teeth? What can they afford because they're on a fixed income? Those are things we have to really take into consideration. With heart disease, we have to reduce cholesterol, we have to encourage weight loss, and we have to reduce fat, especially LDLs, low density lipids that are really bad for them and can cause more issues. In children, let me go back because I think there's probably more on that slide. It's just, with hypertension, we want to be sure that they decrease sodium and they have appropriate calcium and potassium. We want to reduce alcohol. We need to know that if they're lactose sensitive, we need to be sure that they be sure if someone has lactose sensitive, that they either use lactose reduced products or like lactase or different medications that can help with that. Same thing with any disease process. We've got to monitor that. With kids in the first year, we don't give them cow's milk the first year. We give them breast milk or formula. And as they grow and as they increase in age, we not only have to educate the mom on if they're breastfeeding, we have to educate them on the change in nutritional needs from birth to that first year. We have to make sure that they know that as they age, they need more protein, they need more nutrients, specific nutrients. We have to make sure that during growth spurts, they actually do get extra food because they are more hungry. As they increase activity, they need more calories. So we have to make sure that we increase their food and nutrition based on their age and their activity requirements. Usually kiddos, when they're hungry, they let you know, and they kind of regulate themselves that first year. They'll eat when they're hungry. If they're not, they won't. Also, when you're pregnant, you need additional protein, calcium, iron. Folic acid is very important for brain development and fiber. During lactation, extra protein, extra folic acid, and calcium. Once again, that baby is developing based on what you eat. Specific modified diets can be related to any kind of treatment or condition. So that modification can include textures, nutritional levels, frequency and timing, smaller meals, more frequent meals. We may need to get rid of foods that they cannot tolerate when they're allergic to things. Prenatal vitamins are very important. Sometimes during a prenatal prenatal treatment, they're also given iron supplements, IV. Normally, most people can just take a prenatal vitamin that's prescribed and it's enough nutrition, but not always, and so we can give those via injection or IV. Drug therapy. When someone is getting specific kinds of drug therapy, it can change the way they can intake nutrition. So we have to be aware of that. We also have to be aware of the way people consume foods. People may not always be able to consume foods by chewing. They may have a PEG tube, a J tube. They may have some kind of nutritional needs. So we need to meet, and if they have some kind of absorption issue, we need to be sure that we're aware and we monitor and make sure that they're getting the right nutrition that they need. What are the factors that affect that physical issues? So the physician has to consider patient's age, health status, things we have talked about, but those are specific questions that you definitely may be asked as a medical assistant, what might affect the patient's nutritional status. So be sure that you're looking at this particular little quiz, because you might see it again. Changes in texture have to do with modifying to a soft diet. Eliminating foods from the diet generally is related to allergies. Food exchange system is related to diabetes. Decrease in metabolism is related to, as you age, you have a decrease in metabolism. Hunger is usually driven by, in children, is driven by their need to eat. Reduced sodium is related to heart disease generally. GI bypass the GI tract would be when you needed some kind of IV therapy related to parenteral nutrition. Parenteral nutrition is like a PEG tube or J tube that's placed. And then drug therapy may alter the way that we absorb or intake food. So let me see where we are on time. We have still got time, so I'm going to keep going here. Eating disorders. Now, we have discussed eating disorders a little bit already this year, but they can be very harmful. When we talked about psychology, we talked about eating disorders and how harmful they can be to an individual. So anorexia is when people starve themselves. It's a chronic condition. It can be fatal. Bulimia is binging and purging, so they'll eat a large amount of food and then they'll vomit it up. It's usually easier to treat than anorexia. We can modify that with medication and therapy. The goal is to establish a healthy weight, better eating patterns, and figure out what triggers that. People, though, suffer from anorexia and bulimia their whole lives. They have times that they fall back into old bad patterns that are harmful to them. So we have to be aware when we have a patient that has had an eating disorder that we monitor, we kind of look at their teeth, because if someone's bulimic, then they throw up, the stomach acid eats their teeth down over time. They're going to have more issues with their mouth, sores, ulcers, things like that. Also, another thing to think about with anorexia is weight fluctuations, and patients will come in and they'll wear baggy clothes. They may even add things that are weighted to their pockets. I had a patient one time that would put fishing lures or fishing weights in her pockets when she would come in, so we couldn't tell that she had lost more weight. The best thing we have to do to these people, what we can do for these people, is report it to the physician and give them help. If they're skipping meals, if they are they're eating uncontrolled large amounts of food, if they have social anxiety, if they start avoiding crowds, they start avoiding their friends, if they are focused on their weight specifically, if they're constantly talking about how obese they are or how bad they look, we need to take that into consideration and sit down and talk to our patients about that and see what they're doing or why they feel that way, and see if we can get them help. Also, that need to control food because they can't control other things in their life is a big thing with eating disorders. So when they feel out of control, they can control what they eat. They may not control anything else, which is why we see it so often in teenagers. Okay, so we have to document weight loss, report to the physician, and if they're suffering from an eating disorder, try to get them psychiatric help. Patient education. So this is a big thing that as medical assistants you will do. Patient education to reinforce, re-instruct, and make sure that they understand what absolutely is needed for their diet. We have to make sure that we give them examples, show them plates of food, show them how internet sources to use that are reputable to help them become a wise consumer. Show them how to read labels. You'd be surprised at how many people don't understand what a serving of something is. Like the bag of chips that you buy in the store, that's 2 servings. A 20-ounce soda, that's 2 servings or 2.5 servings. Those are things that you have to teach patients, that they don't understand what a serving is. They don't understand how to use a smaller plates are better. It's okay to leave part of the food on their plate. You don't understand how many older people will not leave food on their plate no matter whether they're hungry or not, because that's how they were raised. They were raised to eat everything on their plate. Have them look at alternatives for food. Like, you don't have to buy a name brand food just to get a good source of nutrition. Let them tell them to compare labels. If it's the same thing, it's the same thing. Go into alternative stores like Aldi or just different Save a Lot stores like that, where they can save money and get better food, better nutritional options. Factors that play a big thing is people's taste. So, and as we age, our tastes change, and as we get much older, then our sense of taste kind of goes away. We have to think about disease and disorders and their psychological condition. People who have Alzheimer's, dementia, or other mental disorders may not eat because of the way that their brain is functioning. They don't remember they didn't eat. People with schizophrenia or other mental disorders may think there's poison in their food. You just have to take all of those things into consideration when you're talking to someone about nutritional needs. Also, when people don't like a type of food, like I used to think I didn't like Brussels sprouts. Well, I found a way to cook them that I do, that I can. And so we talked to them about different ways of cooking foods, different seasonings, different spices, things like that have no adverse effect on their condition, but can make that particular food that they need, that leafy green they don't like, they can make it taste better. So just take those things into consideration when you're talking to a patient about their diet. Teach patients about guidelines. Teach them that those are individual things. Sorry, guys. Got to go back. It's not wanting to do the things I needed to do. Which means to teach the patient on an individual basis. One of the worst things, or one of the things I always hated, is that we would teach patients diabetic education as a classroom, or in a classroom kind of setting. That's not good for most people. It doesn't work. Make sure that you're explaining it and that you're using small amounts of time. They may have to come back 2 or 3 times, but they can't ingest everything about a diabetic diet in one session. Talk about good eating behavior and reinforce that to them, that you're proud of them. Explain it where the patient can understand. Don't talk to them like an educated medical professional if they have a 3rd grade education. Also, make sure your patient's an active learner. Ask them questions. Let them answer questions for you. Have them tell you what you told them. Give them a written diet plan. Show them what it looks like. Give them pictures. It's kind of like when you teach, it's kind of like writing an essay. You tell them what you need them to know. But then for like the middle of the essay where you tell them what you're going to tell them, well, in the end, make sure they can tell you what you told them. Otherwise, they didn't learn. They just sat there with deer in the headlights. So make them an active learner. Give them something hands-on to do. That makes it so much better. Put a food puzzle together. And then suggest support groups. There are support groups all over at hospitals and churches and stuff for different type of disease processes. Suggest that to your patient. We have to remember cultural needs, cultural considerations. They influence the way that they buy food, where they do buy food, things that they can and cannot eat, um, when they eat, times that they eat, or times that they fast. There are cultures and there are religious um, sects that they only eat at certain times. They may not think that you should take a pill as a supplement. They may not believe in snacking. They may not believe in big meals. They may, so we have to think all of those about all those things and adjust the meal plan for the patient individually accordingly. Also, think about outside resources. Give the patient websites, like I said, Overeaters Anonymous, American Heart Association, American Diabetes Association, the American Cancer Association, all have great places for people to find information. So what do you need to consider when you're teaching your patient about nutrition? All kinds of things. Their likes, their dislikes, their circumstances, disease and disorders, their psychological status, their knowledge status, and what kind of education they actually need. So I'm going to flip through this summary real quick, and we will be done with nutrition, and we will pick up. With emergency situations. All right, you guys have a great day. Hopefully everybody's got all the information they need from this, and I will be back with you later. Thank you.